Hi, I'm Dr. Zachary Simmons, and I'm the director of the ALS Center at Penn State Hershey Medical Center. We have a large ALS clinic and also an ALS research program. I very much appreciate the opportunity of speaking to you today, and I want to thank the ALS Association Greater Philadelphia chapter and all the other people involved in this event for inviting me to speak. My talk today is going to be what's new in care and research, and hope you enjoy the talk. So I wanted to spend a little bit of time talking about the epidemiology of ALS. So the lifetime risk of ALS is a bit higher than one might think. For somebody born today, there's about a 1 in 400 chance that they'll develop ALS. And that risk is slightly lower in women, slightly higher in men. The average age of onset of ALS is between 52 and 66 years, but that can be somewhat deceiving. Because if you look at this curve, this plot that's in the lower right hand of the side of the screen, what you'll see is that the chance of getting ALS actually rises after that age and peaks in the early 70s. So if people do not pass away from other causes before they reach their 70s, they actually have quite a high chance of developing ALS in their 70s, which is why we see so many individuals in that age range presenting with ALS. Now, the pathogenesis, meaning the actual reason that ALS causes the loss of motor neurons, is in some ways simple, but in other ways very complex. Now, when I say it's simple, what I mean is that people become weak, and they become weak due to the loss of motor neurons in either the cortex, which is the upper part of the brain, or in the lower part of the brain, the brainstem, or in the spinal cord. And so we speak about upper motor neurons and lower motor neurons being lost, but sensory neurons are spared, meaning sensation is preserved, and ALS is often, although not always, painless. And autonomic neurons are spared, meaning that automatic functions such as heart function are not impaired by ALS. So that's the simple part. The more complex part is that we don't understand the reasons behind the motor neuron loss, although we know that it's likely due to multiple factors. And I think it's best to think of ALS not as this disease with one cause, but as a syndrome. In other words, it's a variety of causes that all produce motor neuron loss. And there are many pathways to get to this. I've listed some of them here. And the fact that there are a lot of technical terms here is not really the point. The point is that a lot of things go wrong in the motor neurons of people with ALS, and all of them lead to motor neuron loss. But right now, we're not sure of the order of those or whether they're all equally important. The other thing I've added here is that about 10% of ALS cases are familial, meaning in about 10% of individuals with ALS, they'll be able to identify another close relative with ALS within their family. One thing that's important to realize is that ALS is often misdiagnosed. And when I see individuals with ALS, they're often quite distraught that it's taken so long for their doctors to realize that this might be ALS and to refer them for further evaluation. But it turns out that unfortunately, this is common rather than rare. The time to arrive at an ALS diagnosis is about a year. And trying to make an earlier diagnosis runs into several complications. The first is that ALS resembles more common disorders. So if somebody comes in with a weak hand, it may very well look like carpal tunnel syndrome or a pinched nerve in the neck to the physician examining them. ALS also is rare relative to these more common disorders. And so again, ALS doesn't occur to many general physicians as the initial diagnosis because of course they see lots of other things in their practice which are more likely. And thirdly, there isn't a definitive biomarker beyond the history exam and EMG, meaning that we can't do a single test and say, oh, this is definitely ALS. I also wanted to emphasize that although one of the myths of ALS is that individuals remain clear-headed throughout the disease course, it's important to realize that more than half of people with ALS have some degree of either cognitive dysfunction, meaning a dysfunction of their thought process, or behavioral dysfunction, meaning that they have an alteration in their behavior, usually becoming either more apathetic and withdrawn or inappropriately outgoing. At 10% of these people are severe enough to meet criteria for what we call frontotemporal dementia, and that can really be quite debilitating. This can cause people to not be able to make rational choices. It can cause them to have poor judgment. It can interfere with their ability to process language, and overall can be particularly difficult to manage when an individual is at the point where they need to make decisions about extending survival, deciding on what their goals of care are, and so forth. Genetic testing is an important thing to understand in ALS, and I put it up here in terms of what's new because the availability of genetic testing and the low price of genetic testing are quite new. So if one looks at individuals with familial ALS, that means individuals with at least one other close family member who has ALS. And if we do a panel of gene tests on that person to try to identify the gene causing their ALS, we'll find the genetic cause in about 2/3 of these people, about 60 to 70%. That still means, of course, that of people who have a known family history of ALS, in 1/3 of them, we can't identify the gene that causes it. But knowing that we can in 2/3 is a huge advance over what things have been in the past. Sporadic ALS, or ALS in which there's no family history of ALS, can be caused by some of these known mutations, but we find them in only about 10% of those individuals. So if somebody walks into my office and they have ALS and they don't know that anyone else in their family has ever had it, and we do a genetic test, there's still a small chance that we may find a causal gene. So that person's other family members who transmitted it to them may have passed away at a young age and never developed ALS. Or they may not have received medical care that allowed an ALS diagnosis to be made, or the person may just be unaware of a close family member that had ALS. Genetic screening panels are now offered for a large number of ALS-associated genetic mutations, and these have to be used with care. There are no approved treatments that are specific for genetically based ALS. There are experimental ones, and I'll talk about those in a few minutes. But if you prove that someone has genetically based ALS, it doesn't at this point change their approved treatment options, although it does make them eligible for some trials. There are no approved medications that can prevent the development of ALS in carriers. So if one finds out that a patient has ALS and that patient says, oh, I have 3 children, and the individual has genetic testing done and a mutation is identified, and then one of the children wants to know if they carry it, and then the child is tested and they indeed carry that genetic mutation, there is unfortunately no way to prevent that individual from developing ALS. And so there are emotional consequences of a test that can be significant. And these all have to be considered when offering genetic testing so that people are fully informed about these. Prognosis, this is not new, but I just wanted to add this before I go on to new treatments to put things in perspective. So ALS, of course, causes a gradual loss of voluntary muscle use, and individuals usually die from respiratory insufficiency or they aspirate and develop pneumonia. And the duration of the disease, the life expectancy remains short in ALS, about 2 to 3 years on average. About half of people die within 3 to 4 years. 80% die within 5 years and 90% within 10 years. So there is a long survival curve. And when I talk to people, I tell them, don't expect that just because you have ALS, it means by definition that your lifespan is limited to 3 years or so. You could be one of these people who live for 10 years or longer. And indeed, I've been following people with ALS who live for far longer than that. It's just that we can't predict when somebody first comes in which of these prognosis groups they'll fall into. So knowing all that, what about treatment? Well, first there's current treatment. So current treatment, of course, consists of multidisciplinary care. It consists of management of symptoms, and it consists of disease-modifying therapies. So I'd like to talk about what I'll call disease-modifying therapies, which would be treatments that can alter the natural history of ALS. And it all began in the 1990s with riluzole. And these 2 curves that are on the left here simply show the difference in survival between people who were taking riluzole and those who were taking placebo in the original trials that were done for riluzole in the early 1990s. You can see that the 2 curves separate from one another, meaning that the placebo group did more poorly than the group treated with riluzole. And as I note over here on the right, riluzole extended survival by 2 to 3 months in these initial trials. Now, people will often come in and say, gee, I don't know if I want to take this drug. It's going to give me 2 or 3 more months of life. What does that mean? But actually, that's deceiving. The survival benefits appear to be quite more significant than that, probably in the range of 10 to 19 months when the drug is started earlier in the disease in patients who receive optimal care. So remember that these studies were done in the early 1990s in individuals who had quite advanced disease. But if one starts them earlier in the current era, the advantage in survival is probably quite a bit more significant. Edaravone, which goes by the brand name Radicava, also is able to affect the natural course of ALS. Now, unlike riluzole, in which survival was assessed, in edaravone, the assessment was on the rate of progression. And patients with rapidly progressive disease, but who were in the early stages of ALS, were the ones that were found to benefit. It's important to realize that edaravone did not show changes in rate of progression in all individuals with ALS, but did show it in this subgroup of rapidly progressive patients early in their disease. And it's important for individuals to know that when edaravone is prescribed. So what's new? What's novel? So one novel drug that's been very exciting lately is a sodium phenylbutyrate torsaldiol, which is a drug made by a company called Amylyx, and so far just has a number, AMX0035. What this drug showed was that the decline in function over time in people with ALS was slowed compared to placebo, so very similar to what was shown in edaravone. But in addition, other studies of the data have shown that survival was enhanced by a median of 6.5 months when the investigators compared individuals who were originally randomized to the drug versus individuals who were originally randomized to the placebo. And so given the benefits in slowing functional decline and the benefits in survival, the company has submitted a new drug application to the FDA. There was recently a meeting of an advisory panel. The recommendation to the FDA by that panel is not one that the FDA must follow. It's just simply that, it's advice. The advisory panel had a split vote, 6-4, where they recommended against the FDA approving this drug. But as I said, the vote was close. There were many ALS advocates at the meeting, and the final decision by the FDA should be out by the end of June. In the meantime, the company has made an expanded access program, or what we call a compassionate use program, available for individuals who have ALS. So there are other novel therapies that are worth considering as well. So one can look, for example, at this category of familial ALS that we call SOD1 ALS. And the type of therapy is called antisense oligonucleotide therapy. And it was pioneered by Biogen using a drug called tofersen. And there was a study that occurred in which the primary outcome measure, meaning the rate of decline in function over time, did not reach statistical significance. So it was disappointing in the sense that the drug was not an unqualified success in that trial. But there were signs of reduced disease progression across other, what we call endpoints, other ways of measuring disease progression and disease severity. So as a result of that, the fate of this drug is still up in the air with regard to Biogen's next step. But in the meantime, they are offering it through an early access program to all individuals with SOD1 ALS. There are also treatments being looked at for another form of familial ALS associated with a mutation called C9orf72. And there are actually 2 placebo-controlled ongoing studies, one by AI Therapeutics and one by Transposon Therapeutics, both of which are small studies, but both of which are geared specifically toward people with this genetic form of ALS. So I said earlier that there are no approved therapies for people with genetic forms of ALS, and that's still true. But one advantage of knowing whether somebody is carrying the SOD1 gene or the C9orf72 gene is that if they are, they may be eligible for these ongoing treatment trials if they're interested in them. What about stem cells? So stem cells are certainly a hot topic of conversation and a hot field of scientific research. So there's a company called Brainstorm Cell Therapeutics, which just recently completed sponsoring a study on stem cells. There were several centers involved, and the paper was published in Muscle and Nerve in 2021. These were stem cells that were taken from the bone marrow of individuals, grown in a lab, matured into cells that produce large amounts of certain nerve growth factors, and then they were given back to the same patients. In other words, they got back their own stem cells via spinal tap. And this was a phase 3 study, meaning it was a study that was large enough and powered well enough to potentially lead to drug approval, but unfortunately it failed to meet its primary goal of slowing disease progression. However, as with the other drug I mentioned earlier, there was a subset of patients that appears to have responded. So both the sponsor and the investigators will be looking back to see if further studies should be done. I did want to mention another exciting study, which is the Healy platform trial that is being coordinated through Mass General, but has multiple sites throughout the US that are participating. And the unique thing about the Healy platform trial relative to other standard drug studies that we and others have done for ALS is that it's a series of drugs trialed at multiple sites with different mechanisms. In other words, the first 3 here, which we'll call regimens A, B, and C, were all started around the same time, but then the 4th drug was recently added, and then a 5th drug was recently added. Now, because all of these studies are time limited to about 6 months, what happens is the first studies drop out gradually over time in terms of their use, unless people opt for being on an open label extension. But as those studies are completed, new studies are brought on. So there's a continuous stream of studies being trialed for ALS as a result of this Healy platform trial. And the goal is to accelerate ALS drug development by using one platform, in other words, one set of rules and criteria to trial multiple drugs one at a time, one after another, and accelerate drug development. One thing you'll notice on this list is that all of them have different mechanisms of action. And that reflects a couple of things. First of all, it reflects that we don't know what the most important mechanism for causing ALS is. And secondly, it reflects the fact that we think we can use more than one drug eventually to try to address multiple areas of damage in ALS to try to reverse the process or to at least slow progression or stop progression. Other ongoing trials, I've listed a couple here, but there are a number of others. I've listed one by Cytokinetics. I've listed another by Sanofi, and you can see again, these are different mechanisms of action. So potentially in the future, what we'll be looking at will be treating ALS with a cocktail of different drugs which address different mechanisms of action. I wanted to end here by just saying a couple brief words about what I think is an important technological development, although not a new drug therapy, but it is, I believe, a way that we can improve quality of life for people with ALS, reduce their burden, and reduce the burden on caregivers. This is telemedicine. So how can one use telemedicine? So if you think of telemedicine conventionally as being the physician sitting in front of a computer in their office and the patient sitting in front of a computer in their home, then telemedicine can be used in a few different ways. You can use it to substitute for regularly scheduled visits with the multidisciplinary team. So this would be for people who can't travel to clinic. But you could also use it to decrease the length of time of an in-clinic visit. For example, if you had one-on-one video conferencing before the clinic visit between the patient and individuals who did not have to perform an examination but needed to speak with them, then you could reduce the time in clinic for examinations when the individual came in. So some individuals to consider using in this model in terms of the home visit would be the social worker, for example, or the psychologist or the nurse, who have important jobs to perform and important information to collect, but don't necessarily need to examine the person in order to do what they need to do. Then you could reduce the burden on people when they come into clinic because the visit would be shorter. And you could use it as needed for urgent matters. How about one-on-one video conferencing with selected team members that are triggered by communications from the patients or their caregivers? So the person calls up the nurse and has a specific concern. And the thought is this would be better settled via video visit than via simple phone call, and it's too hard to come into clinic. That would be another option. And what I've shown here, this is a very busy slide, and it's not necessary to look at all the details, but the point of the slide is to show that one can monitor home respiratory function using what I'll call remote pulmonary function tests. And the fact that looking at both of these graphs, that the lines pretty much parallel with one another and that the dots all fall along the lines tell us that remote pulmonary function tests performed at home with a small handheld device coached over video by a respiratory therapist get results that are as good as if you come into clinic and do the pulmonary function test. So maybe we can do this in advance, reduce the burden in clinic as well. And there's lots of other stuff we can potentially do. On the left here, we've started doing a study here where we are doing gait assessments. We put a monitor on people and it measures their length of their stride and it measures the speed that they alternate legs. And so overall, it tells us quite a bit about their walking. And the goal is to pick up changes early on before individuals fall so they can be brought in to see a physical therapist or given a walker or given a foot brace or whatever else they need in order to prevent falls. The images on the right show that one can also track bulbar progress, that is speech and swallowing, by using a microphone and a cell phone-based app to look at speech and swallowing. And we're doing that study here as well, using, again, a microphone to look at the frequency of swallowing and the clarity of speech through a speech analysis. And finally, the only use of telemedicine doesn't need to be limited to clinical care. It can also be used in research. And so if one could have some research visits done remotely, then more people could potentially participate in ALS clinical trials because some of their visits could be remote and overall the trial would be less of a burden on them. And that's something that during the COVID pandemic was implemented and is continuing to be implemented now post-pandemic. So that's all I wanted to review today. I know that's been brief and sort of a whirlwind of information, but I hope it gives you a bit of a feel for what's new and where a few fields are going, where a few areas of investigation are going in ALS. I want to thank our patients and our caregivers, some of whom are sitting in this picture here, which I really like. And I want to thank you for your attention.